I mentioned it in my previous email, we're doing a series of outreach since we can't physically be out in our communities. So the purpose of these conversations and these interviews is to really engage with folks on how we can educate and continue to educate our community members, whether that's through scientists, through our outreach partners, through other cancer survivors. We really want to continue the conversation of cancering our outreach efforts and our own communities on this topic. So we really appreciate that you're with us today and that you're taking the time to and answer the questions that we have sent you. So thank you again for that.
No, happy to. So, I apologize, and I'm going to tell you beforehand that because of the COVID-19, I may just get pulled in for some orders or things in the middle. So I will try to limit the interruptions, but it's just been a different, very unusual for us.
Absolutely.
I'm sure, like for all of us, actually,
Yes.
I shouldn't say just for us, it's for all of us, you know, it's just been really unusual and how we are doing things in the clinic and things like that, just getting pulled into like 15 directions at the same time.
Yeah, understandable. Absolutely.
Okay.
So with that, I think we can begin if everyone's okay with that. We can go ahead and start the meeting. And
Okay.
as other individuals join us, they'll hear along with our conversation.
Okay.
And Dr. Chalasani, you do have the option of doing the video and turning on your camera, but no pressure. I understand that.
I'm happy to. Just that I think it's a very late one. Okay, there we go.
Hello.
Hi there. Yes, you know, this is slowly getting better. It's just like when the whole thing started. I think the other day I had like some of the patient video calls, totally like just suddenly going on. Didn't realize that I was still just in my casual clothes. And I was like, my patients know me pretty well, so they're okay with. They were excited to see me in different clothes other than my things, but for new patients, it was a little bit odd to tell them I'm usually not like this. Anyway, thanks for giving me this opportunity. So I'm, as you know, like I'm a breast cancer medical oncologist here at the University of Arizona Cancer Center. I see patients, you know, 2 days in a week, but I have a busy clinic. And then the other days, they're split between my research and administrative times. So I have a lab in the cancer center. It's on the 4th floor. My lab is just a translational biomarker based lab. It is not a wet lab, so I don't do any kind of mice or, you know, try to like a lot of cell cultures. There are just a few based on experiments, but it's a biomarker driven thing. So what that means is I have a lot of clinical trials that I'm looking, okay, what's causing what? And then, you know, I try to get those studies done in my lab. So I'll go over that in a few details. For the that's from my research and you know, just giving a big 10,000 view overview of just what I do. And then from the other part is from the educational one, I'm the program director for hematology oncology, the fellowship program. So that is after, you know, all of us finish med school and then 3 years of residency, then we do 3 years of hem-onc fellowship, and then, you know, we certify and we can be trained as oncologists. So I'm the program director for our program here. I was a graduate of our program, both for internal medicine residency and the fellowship. I was here for all my training. And then I stayed back as faculty and, you know, I started in breast cancer. So now I'm the program director. It's just kind of a weird feeling just being in that role, just knowing that because I was on the other side for so long on this end and didn't think I would ever be a program director, but it's kind of, it's a different role and something that I'm trying to slowly get adjusted into. But our fellowship program has 12 fellows. We have 4 each year. So that's where from the thing comes from. So I'm just going to go over your questions, Gabriella, if that's okay. And then maybe that way I'm like not rambling and tell us about that.
No, yeah, no worries. So what we were planning to do is just kind of go through the questions, kind of like an interview, informally. And yes, thank you so much for introducing yourself. That covered a lot of what we wanted to get across, just a bit of as means of introduction. But yeah, just a heads up to everybody watching, in case we do need to pause today, it's because Dr. Chalasani does need to go attend to her duties as a physician during this coronavirus COVID-19 outbreak that has us all working from home, but cancer does not stop. So Dr. Chalasani is, if she has to answer the call, we will absolutely pause. That is our priority. But yes, thank you so much, Dr. Chalasani. So Dr. Pavani Chalasani, I'll give just a quick intro here. Dr. Chalasani completed her medical school at Gandhi Medical College in India and completed her internship, residency, and fellowship in hematology oncology at the University of Arizona. Dr. Chalasani is an assistant professor on staff at the University of Arizona Cancer Center. She specializes in breast cancer and sees patients with breast cancer for treatment decisions regarding hormonal therapy, anti-estrogen therapy, chemotherapy, and second opinions. She's also the co-director for Hemophilia Treatment Center, Adult, at the University of Arizona, and sees patients with bleeding and clotting disorders. In addition, she's very active in research and has several ongoing translational and clinical.
Oh, and I think we might have lost him. Maybe lost Octavio's connection. Yep, I think there's a technical difficulties there. But nonetheless, Dr. Chalasani, you had introduced yourself as well. So, again, thank you for being here. And in an effort to be courteous of your time, I'll just jump into some of the questions that we had. So why did you, Dr. Chalasani, choose to have a focus on breast cancer research? What's the background to that?
So I've got to tell. So I was, interesting thing is when we have fellows and they're trying to figure out what their focus of interest is or things, because as we train in hematology oncology, we study everything, like all cancers and all, all malignant, like both blood disorders and solid tumors. In academic practice, we get to subspecialize and choose it. Sometimes it's hard because you don't know which one you want to choose, right? So you develop a natural interest, or people have an area or some kind of story or have a personal connection. I didn't have any such thing. The main thing was I just wanted to be an oncologist because I thought that was in terms of patient care and also in terms of just what I could offer and like the research. Every single thing about oncology was just very exciting for me. So that just spoke to me in so many ways. So I just wanted to be an oncologist. I know what I wanted to do. First year into my fellowship, I was pretty sure I'd be a leukemia doctor, hands down. My research, I studied projects and did everything. And that's just because of the way our training goes. We are a lot of, inpatient based, have this like high risk acute leukemias, really sick patients coming in. We do this induction treatments. We do this like procedures, it's kind of this fast paced, things which happen with leukemia, but the outcome, it's not exactly the same, but you get into that adrenal rush and you're like that excitement phase and you're like, oh my God, this is what I want to do. And I totally loved it. Absolutely. When I was my first year and I'm like, okay, that's what I want to focus on, but try to do it. Worked on research projects because, and that's what I always tell my fellows is like, just work on a research project. It doesn't matter where it is, which specialty it is. It's just learning how to do it. So I did that. And I think by like mid-second year, I was just not sure for malignant hematology. I wanted to continue just because for me, like the way how much OCD I had and like how I need to follow up on my patients and things like that. I just didn't think I could do that for leukemia. It was just not my cup of tea, like I just have too many things and I could just see myself being wired up like pretty much all the time. Just not being able to let go. And, eventually we will, but I think it's just like some of our personalities, and thank God I had my realization when I was a fellow and not like as a faculty member. So I just didn't think, and my interest kind of died down. And honestly, for solid tumors, I was rotating, we were still rotating about all solid tumors. Like breast cancer was the only thing like I really enjoyed. Like, I had a good way, like, pretty much like 99.5%, I should say, of my patients are women, right, in breast cancer. So I just felt like I could connect, it's just like chatting, and had a really good connection with pretty much all of my attending patients when I was rotating. And I was like, oh, this is really good. But honestly, like I was very particular, and I wanted to do an academic job. Like I wanted to focus on one specialty, learn and research. I'm kind of a mentality that I'll go. If this is a job, I'll give my 100% and I develop and do it. Like I'm kind of an easygoing, like I didn't have to like be attached to something, but breast was something I really liked. And I was like, oh, that seems interesting. And honestly, at that time, there was a breast position. They were looking for a junior faculty desperately. So they needed one. So I did, and I started, and I think about 6 months or like 9 months into my job, I was talking to my mentor, and I was like, I have no idea why I even thought I would be doing something else. Like, so it's not that something I was like, this is what I want to do. I thought it was a good fit for me, but something I just like fell in love with it completely once I started. And now like 8 years into it, there's nothing else I would do ever. So I think it just happened. Like, so there were multiple things. The position was there. And, like I said, it also depends on us and a personality too. In terms of research, it's just that I've always been interested in translational research, but like I was telling earlier, translational research can be like tumor agnostic. Like, I could use this biomarker development for lung cancer too, or maybe head and neck cancer, because, it's like studying the tumor biology and figuring out what is in the cancer, like what is that marker in the cancer which is making us predict, okay, this is why this treatment is working, or this is why we are able to detect it because of this marker in the cancer. So that could be applicable to all. So that was my interest, is to study biomarkers, and that was something I worked since I was a fellow. And like I said, I worked on with the leukemia, but again, understanding the hypothesis, the whole rationale, and studying, trying to get information, it's the same, no matter which one it is. So that's what I also try to tell my fellows, that yes, you're interested in leukemia, but if there's really cool like lung cancer project, go and jump for it, because that kind of experience is invaluable. So I try to talk to them about it. So so that, so my interest was biomarkers. So it was kind of, very easy to narrow down. And honestly, like once I started doing breast cancer, like narrowing down, like breast cancer has like the most advocacy. It has the most outreach. It's definitely like 200,000 cases every single year. The incidence and the prevalence is so much, and the advocacy and the funding and everything are high. So it kind of like, I was able to develop into just give me 1 second.
No problem.
I'm sorry. I have a fourth year and a fourth grader and a second grader who are trying to figure out these remote classes.
Yes.
Since the whole COVID-19 thing went, both me and my husband, both of us are physicians, right? And we had no time. I got an email. Actually, I got a call from my kids' school teacher saying, "Are you guys okay? Because you really didn't respond to me." And I was like, I am. I'm not ignoring my kids. It's just that I'm
a little
like,
busy.
Kudos to you for all that you're doing.
Yeah, like, they will get their homework done. Okay.
Right. So add teacher along with your physician duties.
I was like, I will log them in. I will. So I got them just so that I don't get into trouble. I was like, oh my God, they'll probably send people because thinking what's going on. But
no, that's life that everybody is adapting to right now.
Yeah, exactly. So,
multitasking. Yeah, but yeah, so breast cancer sounds like it was just kind of meant to be. A path opened up for you, and you followed it, and that's great. So just a little bit about breast cancer, since you mentioned it's something that's a lot of people's minds. It affects tons of people. So who can get breast cancer, just kind of as a general overview?
So the main thing is, majority of the women, right? So anyone with the mammary tissue. And then so a few men, who can get risk, but, the incidence is lower in men just because they don't have so much of breast tissue there. So that is just they don't have enough. So that is a reason also. So in terms of women, the risk factors, they're well established. Most of them know. So having early menarche, late menopause, having, a family history, which is pretty significant. Obesity plays a role. Just because there are other things, just then, in postmenopausal women, in addition to obesity, about the estrogen role of the amount of estrogen in the blood, it's also got to do with I'm sorry. Like I said, I've developed this ADHD with all these messages coming through. Okay. So with obesity, in addition to that, it's just, it also got to do with the insulin growth factor receptor and other mechanistic roles that they actually have to go with breast cancer. I'm on a call right now. As that, please. So, so those are the main, the main things that you come up. So in terms of, inactive, not being very active or things like that, physical activity and alcohol intake, it's hard to quantify saying this is the one which is associated with that, but no. I try to always ask patients, when they say, oh, I don't drink alcohol. And I'm like, okay, what do you drink? Anything? They're like, yeah, but just like, it's only wine. So how much wine do you drink? Like 4 glasses of wine. Well, that is alcohol intake. Like, just because it's wine doesn't mean it's not. And that is a lot. So, you try to limit, when you try to discuss about what exactly is going on. So those are all kind of important to go over, and, the risk factors. So you quantify that. Age of first childbirth, like over 30, has been known in the past. So, but not everyone. So, but, it's cumulative, right? So the more number of risk factors, the more we do. So when someone comes into our clinic as a newly diagnosed, we try to go over all. We do a complete past medical history, past surgical history. What is the prior breast history? So in that, and also the gynecological history. So because those are all important, kind of figuring out what the risk factors are.
Mm-hmm. And throughout your career, Dr. Chalasani, have you seen a rise in the diagnosis of breast cancer?
So the incidence initially goes up because of the screening mammogram. So that's what increased in it. But it doesn't mean the cancers are increasing. It's just that we are finding more. So it is kind of that hard thing where to say, is it really increasing? It's just that we are finding more. And now with the 3D, if you're finding even earlier, so the incidence kind of rises, but it's not actually rising. The thing is, let's say if we find this like early pre-cancer now with the mammogram and we are treating it, but if it would have never caused any problems that we in the past and never had an issue. So it's one of those things of overdiagnosis. The incidence for itself, when you look at it, it's like 1 in 8 women is at the risk of developing, breast cancer for postmenopausal women. That's a statistic we frequently quote. And that's kind of been the same, but I think we are just finding earlier diagnosis. The stages, just because of the increased screening. Mm-hmm. Mm-hmm. But that's where the incidence, is it like truly the incidence is growing up, or is it just like an overdiagnosis? So that's the bias there.
Right, that's very interesting. So is that like a certain demographic group, and can you attribute that to a certain thing? Is it just more screening that's happening?
Yep, so definitely more information. There's more awareness, right, in breast cancer. Like I said, it has a huge advocacy thing. For October, we have this like whole breast cancer month, and there are a lot of organizations and women are strong advocates. We, they speak out, and there's a lot of money fundraising or things. So there's definitely more awareness. But having said that, so mammograms are there, but we are here in Arizona, and there's huge discrepancy, and not even all patients can get their mammograms, which is like, suddenly you're like, what do you mean? Like, you never had a mammogram, right? So it's just not that they don't want to, it's just that they don't have access to those mammograms or things like that. So, so those kind of like things play into role about the screening and educating people. So I think people are aware, and the guidelines are there, primary cares are there. These are like established guidelines. So, and have been there for decades, but the actual uptake in the clinic and patient population, you see pockets where it is higher, and then pockets where it's just like no access.
Right, and if a patient's never had a mammogram and they go in for their first one later in life, it could be that it's more at an advanced stage.
And I see patients, age 65, 67, they're coming in with a diagnosis, and that was mammogram, and you're like, where were you in the past like 20 years? What's going on? So, but it happens, and we still see that. Like, I still see them in about a month ago, or a few years, the past year or two, I still see patients getting their diagnosis because that was their first mammogram they had.
Right. And what are the different types of breast cancer imaging or testing that you would recommend?
So routinely, the mammogram that we used in the past was a 2D mammogram. So when the compression was there on the images, they were only like 2D. But now the most, newest thing which happened, and we only have that imaging, we don't have any other machine, is it's called a 3D or a tomo mammogram. What it does is it actually gives a three-dimensional image for us, so we can actually look at and kind of rotate on our screens and can actually look at the 3D image. So that is for a standard screening. Okay, so that is the mammogram. So that is basically like an X-ray. So you give radiation and you take pictures. So it's kind of like black background, you have the white picture, right? So that's kind of like an X-ray. So that is what a basic mammogram is. It's an X-ray, but we have a 2D picture and now with a 3D. So there's a little bit more radiation with the 3D, and frequently that's a concern. Oh my God, I'm getting radiation. But we got to remember, it's like, how many X-rays do you get? And then flying across country, we don't realize the amount of radiation we actually get exposed to, but it's less than that. So we just try to have to educate people the degree of mammogram and the radiation it is. So mammogram is a standard. The other imaging modalities we have is an ultrasound. So ultrasound is basically by sound waves. So you put a gel on the breast, and then you put the probe on it, and then it kind of gets the sound waves, up there. And then when the feedback is there, you get these images. So that is what the ultrasounds are, and they're used for other things too. And ultrasound is used, and for younger women, where when you do the X-ray, it's just like a whiteout because they have so much mammary tissue. It's like a blackout. So it really doesn't help. So an ultrasound is a little bit better, but again, it's not 100% specific. So sensitive is a little bit better, but again, it's not a good screening tool. So this always comes down to what is good for screening for patients. So far, mammogram is the only one which has been shown as a screening tool that if we find early, we can cure cancer, we can improve survival, which is the goal of it. Otherwise, what's the point of screening if you're not going to make a difference in patients, right? So
right,
mammogram
exactly.
is the only one which has validated. Ultrasound is available. Yes, it is a sound waves and it's probe, but it's not exactly anything different. So so ultrasound is, we don't routinely use it as screening technique unless there's a reason. The other ones which are available is an MRI. So where again, an MRI is more, it takes more time. It doesn't have radiation, obviously, because it's just an MRI. It uses like magnetic resonance imaging, that's what it's called. You need to have a special kind of coil to do an MRI. So it's not that if you can get like an MRI of the belly or your lungs, it's not the same kind of machine. You have to, it's the same machine, but you have to use a different coil. So there have to be that MRI has to be especially, it has to have that coil. Otherwise, you can't do a breast MRI. Okay, so it needs a special MRI, and then the patients have to lay down on their belly in the prone position and go into the MRI and then get it. So it's not that comfortable. And again, it's an MRI, so you go into the tube. So it's not ideal for claustrophobic, for anyone who has claustrophobia.
Right, right.
So it's hard to get that. Again, MRI is a really good screening. It will be good if they have dense breasts. So that is where, because you can pick up better, because the mammogram is kind of, like I said, sometimes it's like a washout. So an MRI would be better in terms of looking at that. Not that it's 100% sensitive, but you can at least try to get some imaging information on the MRI there. So those are the three ones. The MRI, they are kind of approved for women who have dense breasts, and those who have a known mutation, like a BRCA1 or 2 mutations, those who have, where we can find, those screening modalities are approved. So these are the ones which are approved and available. There's a lot of chatter about thermograms, and I don't know, there was something else, but it has not been tested. So thermograms, I think, basically goes on the things that cancer and certain things are hot, and you can pick up because it lights up on a scan as a hot thing versus a cold one, but it has not translated. It is very user dependent. It is not available in a random thing. So there are some facilities which offer thermograms for screening, and people like to do it because it's no radiation. However, the technique is actually not validated. It misses a lot of things, or it diagnoses things which are not appropriate too. So it is just not a good, valid way. People, you just want to do better. You want to be healthy. So you are looking into all these alternative ones. And unfortunately, the data out there, and some people just take advantage of some of those things and just make it available. But, luckily, if you educate and kind of give the information, this is what it is, and things are, most of the patients are okay.
Yeah.
Great, and that's why it's great to see you involved with the outreach and getting out in the community and letting people know about all these things so that you do get to actually, help at an earlier stage, because it is true, right, that the earlier that breast cancer is detected, the better the outcomes are.
Yeah, definitely, because early stage has been known to have improved survival compared to the more advanced stage. So the earlier we detect, the better it is, because we can treat it and we can cure it, right? So it has more implications for that. So that is good, because we also have better treatment. So we have more number of survivors, and we don't have patients becoming, stage 4 or dying from their breast cancer. So, and data has shown the earlier stage, the more survival it is. So it is,
Right.
that's why we want to do that.
And the self-examinations too. I've seen you had.
So self-exam is available. It's a hit or a miss, I'll be telling you. So it's
Okay.
not that it is standard as a recommendation, like they say it, but the examination techniques and how to teach and, do that, it's just like so all over the place. And sometimes it's hard and there are limitations. And some, it's like two extremes. Some people don't do it at all, and some people do it like all the time. So it's just like, teaching and education. Yes, there are a lot of patients, especially young women, because they're not even like old enough to start getting mammograms, but they frequently only detected by palpating, right? So a lot of times it's there, but self-exam, while it is, recommended or things, it's not exactly like a standard screening tool, just
Right.
because it is just so controversial in terms of its output, I should say.
Right. And Dr. Chalasani, we're curious. Can you please tell us about your study on metformin to reduce the obesity associated breast cancer risk?
Yeah, so this is for patients who never had breast cancer, okay? So it was early on. So, like I was telling you earlier, for obesity, it's just not for the increased estrogen, but also for the insulin pathway and other things which are related. Metformin has been interested. We have a long story, has been very exciting, and many scientists have always been looking into metformin and its role in cancer. So there are studies going on in metformin, how it regulates the PI3K and or the mTOR pathway, basically, and improving outcomes for cancer. So that one is actually Sherry Chow. She's the PI for the R01 on that, and I'm the medical director for the trial. So what we did was for 150 evaluable patients, we randomized the trial for patients, for metformin versus placebo. And these are just patients who are high risk. So they need to have like a high BMI, so either obese, and then have like a glucose, or have some kind of metabolic syndrome component. And then they get randomized to metformin for about a year versus a placebo. And we are looking at their breast density and changes, because, we can't really look at every single time point, look at how their outcomes are for breast cancer risk, because that is like really hard. But just to know if taking the metformin decreased the breast density as a surrogate marker of breast cancer risk, and to see if we decreased it. So we finished enrollment on that, and the analysis is going on right now. So hopefully we'll have some results soon.
Wow, that's wonderful work of everything you're
doing.
doing.
So we actually did so there is some literature out in patients who already have breast cancer, but this was actually looking in decreasing in the high risk group, and we chose the ones with the metabolic or syndrome, because, there we know that, metformin will be beneficial and things like that.
That's amazing, because metformin was developed for diabetes treatment. Is that correct? Yeah.
Yep, exactly. And then there are patients. So like I said, in the cancer, patients who already have cancer, there was actually a large NCI study which did for the women taking metformin versus none. So in triple negative cancer, we found that, those who were taking metformin versus placebo, it really didn't make a difference as much as we expect to. But in estrogen receptor positive cancer, where we expect this to affect the results are still pending. But, invasive cancer, there's a lot of preclinical data, and also like early phase state clinical trials. We're waiting for the larger trials for the outcomes to be reported. But this is actually looking at, and that is the reason we chose like this obesity and other things, to see if metformin will actually change their metabolic profiling, like making them, the glucose is improves, like, because metformin, you don't really become hypoglycemic. So that's a good thing. So patients with diabetes can take it.
Okay.
So they don't, they don't tank their glucose or things like that, like the other diabetic medications. But it's used more for because it can change the sensitivity for the insulin receptor. So it's much more complex. It's not as straightforward. Like this is a metformin acts. It works like it acts 10 different ways. And I think that's what is unique about metformin. So that is the reason we chose to look at that in the earlier setting in a higher risk population who have increased breast density, but in this overweight obese women with other metabolic syndrome factors, to see if that changes. So but the outcome, we had to find a surrogate because we can't really look at breast cancer incidence. So surrogate was how did it change the breast density, and we did MRIs on them beginning 6 months and 12 months.
Wow.
That's fascinating. So like a bit of outside the box thinking and some creativity there. That's great.
Exactly.
Yeah. So what about your clinical trials? Do you currently have any active clinical trials?
We do. I think through our team, we have about at one given time for the breast cancer clinical research program for patients with breast cancer, we have anywhere from 10 to 20 is what I would say. I know it's a big variant, but it depends on them, which is active, which is closed, or things like that, which are in the startup phase. So we have anywhere from 10 to 20. And those trials, go from early stages, like for treatments before cancer, during cancer treatments like chemotherapies, and then later on, like what kind of other treatments, and metastatic cancer, right? In addition to that, we actually have trials in the prevention setting. So these are for patients who just have high-risk breast cancer. And we also have survivorship trials. So we have trials ranging from prevention all the way to survivorship, and then in metastatic cancer. So all spectrum. For the prevention aspect, I think one of the really cool trials that we have is through the NCI, Department of Cancer Prevention, we have the tamoxifen gel study. So because, tamoxifen is a pill that we have to take for a patient with cancer, but it's actually shown to be decreased risk of breast cancer incidence for women with high risk of breast cancer, right? So we recommend it, but it has side effects and patients don't want to take any, if they don't want to take any pills. So this is actually a gel that you apply on the top of the breast. And that's just be more of a local effect. So it goes in and kind of decreases the breast density. So this is a gel study that we are doing, and it's a randomized phase 2. So it is a placebo versus the tamoxifen gel. And it's about 8 sites across the US are there, and we are one of the participating sites, and that is a really cool trial. And I think it's potentially, if it shows its effect, it will go to a next randomized phase 3, but it will actually be a standard of care setting trial for the patients. These are just for prevention, so they don't have to take a pill compared to this ointment, which has much higher uptake for patients, for people in general, right? Putting something in your body versus just putting it on the topical, and if you're able to tolerate it better, it still has the benefit.
Right. And given all of this, in your experience, and what is your recommendation of valuable questions patients can ask their doctor regarding their own cancer treatment? Do you have any tidbits of really important questions that maybe we should be continuing to garner? One
of the things is, it's good to know, most of the times at a cancer center, because it's NCI designated or things, we have a navigation, we are NAPBC accredited. So we actually have booklets that we kind of give them, and we give them, these are like the ABCs of cancer, because it's not uncommon, but I think I do a great job explaining, have a great rapport, and patients are, yes, they're taking down notes, their families are taking down notes, they're recording me for the entire thing. And then 2 weeks later, they asked me a question, and they're like, oh, I didn't know this was my stage. And I'm like, yes, we talked about that. They are nodding and they are writing it down. They're recording you. They still don't get it. I mean, it's just not knowing that. So in the beginning, I tell them, we are going to have this conversation at a minimum of 3 times. And they're like, no, we got it. And I was like, no, it's okay. You can ask me again. You can still ask me the same questions that we already talked, because I've learned that it's hard to synthesize everything. Because what I try to tell them is, I'm kind of giving you a crash course on breast cancer and treatment, something I've studied and has been practicing, but now I'm telling you in this 1 to 2 hour span. It's hard, and you can only take so much information, right? And again, not everyone's level, it all depends on their education level, what they can grasp, and what kind of language and terms I'm using. You know, we try to dial it down, so it's also on our end too, but it's just hard. So the questions they need to know are what stage and what the treatments are. The main thing is, you know, do they know their options? That's the main thing. You know, if they can just ask, okay, are there any other options, or what are the treatment options, and then, you know, go for that. Google is a hit or a miss. It can give you great information, or it can also lead you in like a totally path, like which is like completely offshoot, and then you're like off the path so much and it takes us longer to come back. But they're reputed site, American Cancer Society, you know, some Mayo Clinic websites and our websites, you know, they have good information because they are vetted, right? So they have good information for the patients to use too.
Mhm.
Right, and I know that at North Campus, you guys have a great team of the Nurse Navigators
Yes,
that
we do. Yeah.
help, well, navigate through all of that
Absolutely.
information. Yeah.
And then towards the end, after they finish the whole treatment, there's another survivorship plan which is put through. And again, like I said, this is a patient who's already finished her treatment. I mean, she got a surgery, she got her chemo, whatever it is. And when Sean is actually giving the survivorship plan, they're like, oh, I didn't know this was what it was. No. And then I'm like, oh my God, you got the chemotherapy and you're telling me you didn't take it. But they do know during the treatments, they're told with it. But it's just, I think just going back, I mean, for me, it's like, I'm so used to the terminology. Of course, you know, they know it, right? But they probably don't. I mean,
Right.
adriamycin cyclophosphamide is a tongue twister. I can just
Yeah.
out. I'm like, what do you mean? You don't know what treatment you
Come
got,
on.
right? It's simple. It's just adriamycin cyclophosphamide paclitaxel. You can't get the name. So it's hard, but you know, I think just those survivorship plans or things like that. So but the main thing I always tell patients is know that you have options. There's always options. There's nothing is like set in stone. Yes, these are guidelines, but the guidelines are, you know, they're not set in stone. That is the reason, because if it's just following guidelines and anyone can just read it and prescribe it, right? But it is not. There's a reason why it's called art of medicine. We need to turn it to talk to the patient and make it personalized, make it, how does the guideline fit you, or how you fit the guidelines, or how are the guidelines actually applicable to you?
Right, there's no one size fits all approach. Everybody's different.
Nothing. Yeah, nothing like that.
Right. So with that, do you think that there's a need for more resources to address like the mental or emotional well-being of patients, caregivers, and survivors here in Southern
Absolutely.
Arizona?
Absolutely. I think there's a huge, and we have like quite a bit of supportive care trials and things going on. And I think that's huge though. I mean, obviously through our cancer center and network, we can reach out to our folks, but there's just beyond that, right? You know, we don't have majority of the patients coming in. So there's definitely an outreach thing there where patients just need to know they don't have to come to us to get the benefit of those kind of trials or to know things like that, to triage. You know, obviously our patients, you know, we are able to give them all those options. So they really appreciate that. But hopefully we can get those access to those kind of trials to like broader population than those just coming to our cancer center. And that is the only reason they can access. But some of the supportive care trials of prevention, they can just be applicable across because it's just education for people just to be more aware.
Mm-hmm. Mm-hmm. And you mentioned the organizations that people can look into. Do you by chance recall any of those organizations that you have seen offering this type of support for communities and for families that they should look into?
I think all of those sites are just public, so anyone can just Google and look at the information. And in terms of trials, I think they may have to just like, you know, type in and look for the trials. Like our cancer center, we have a website, you know, where they can look for the trials, and you look into the research. You know, they actually updated our website recently, so it's supposed to be that. I'll be honest, I'm not that crazy about the way the website looks. I still don't think it's that user friendly. Like I've seen, like even from a physician perspective, right? Like I'm looking in, I want to refer a patient, so I'm trying to navigate it. It's not like the ideal thing there, but you know, it's at least better than we didn't have anything. So, but I definitely think it's there. There are a few universities who have like even much better websites than what we do. So,
But it's a work in progress. We'll get
it's
there.
a work in progress. We are getting there. We are absolutely getting there.
So yeah, one of the organizations you mentioned is the American Cancer Society.
Mayo Clinic has you know, information on that. Susan Komen has good. I think breastcancer.org, you know, that has a good website. So there are like quite a good few reputable sites online.
Excellent. And then looking down the road for October, I know the American Cancer Society does the Making Strides Against Breast Cancer walk here in Tucson.
Yes.
Was downtown last year at Armory Park. Hopefully everything is going to be
Better by then, right?
better
And
by then,
we'll
and we
definitely
can
have it.
all do that mass gathering again. So are you participating in this year's event? Are you putting a team together?
So we will be. We haven't put
Okay.
into a team yet, but I know that is something we will definitely be looking into. So we would love to have you guys, because we cannot tell you how appreciative you were of your efforts last year. Oh my God, we strongly feel from our end.
Yes, it was great. And then I know Gabby was
We
out.
really, because we think our outreach went better because of you guys helping us out.
It was a great time.
It's always a collaborative effort, and we're always very lucky to be connected with such great partners.
Yeah, so we will definitely get our research pamphlets. We are better this year. Last year we kind of had to get it, but this year we'll try to be prepared. We'll get our research pamphlets. We'll get both in English and Spanish, and also our clinic things pamphlets too. So just to get some information, and we'll try to work on getting some just education materials out. So we'll try to prep it better. But we are hoping definitely we could do that again.
Yes, and I know Sean, who you mentioned earlier, Sean Mulligan, one of the Nurse Navigators of the breast cancer team right there in North Campus. She's great getting the team together. And then I know Gabriela helped, I think, with the translation of those pamphlets into Spanish. So that would be great to have more Spanish resources out there for everybody.
Absolutely.
Yeah, and
looking forward to that.
We're so looking forward to continuing this partnership, and we can't thank you enough, Dr. Chalasani, for joining us today. We appreciate your time. You have a very hectic schedule, but nonetheless, thank you for helping our own community members learn about
absolutely.
and continue to educate each other. So thank you again for your time, and we look forward to connect with you again soon.
Absolutely, and hopefully sooner. So if you guys have any outreaches, send me a quick email and I'll get you our breast cancer pamphlets. Okay.
Absolutely. Thank you so much for joining us today, Dr. Chalasani. This was great information. Any chance that we have to get that info out there, hopefully can connect with somebody, and that'll make the difference. So we're going to be posting this webinar online. I believe we're going to be putting together a YouTube channel. So anyone who wasn't able to join us today live will be able to go back and look at the recording. And then down the road, we're going to have some upcoming webinars that I wanted to plug here really quickly. So April 14th, we're going to have Santos Islas talking about surviving cancer. On Wednesday, April 15th, we're going to have Lorena Verdugo from Ventanilla de Salud and El Rio. That one's going to be in Spanish, and we're going to be talking about binational healthcare access being so close to Mexico. It's something that, diseases do not know borders, so we got to address this as a community-wide thing. And then April 16th, we're going to have Kellen Palingwantewa from talking about from Native Americans for Community Action, and going to be talking about colorectal cancer among American Indians and Alaskan Natives. Again, thank you so much, Dr. Chalasani, for taking the time. So some great information. Once again, if people are interested in seeing if they can participate in one of your clinical trials, maybe clinicaltrials.gov, is that where they can find them?
Clinicaltrials.gov, it has everything, but even our website has all information too. But, they can just feel free to just reach out to me also. We are pretty open, like our team is pretty open to and happy to navigate.
Perfect, so we have your email up on there. Hopefully, if anybody wants to reach out, they can reach you through there. Thank you so much.
Thank you. Have a great
Take care, okay?
Your time.
Bye.